Welcome, everyone. My name is Eric Klok. I'm an internist from Leiden, the Netherlands, and I'm extremely honored to be invited to give a webinar together with two VTE giants, Dr. Anette Hoyen, who is a senior researcher at the Danish Center of Health Services in Research, and Professor Stefano Barco, who is a vascular physician in Switzerland. And we are very happy to be part of the Thrombosis UK National Thrombosis Week. And we have three presentations prepared on the impact and long-term outcomes of patients with venous thromboembolism. And we really hope to discuss this with you, and we hope for your active participation. And hopefully also you have many questions for us, which you can put into the Q&A. And after each presentation, we'll have 10 minutes or so to discuss with you, hopefully, and we'll be very happy to answer any of your questions. So without further ado, Anette, you will start off, and also I have to apologize because after your presentation discussion, you have to leave to do something very important. So that's of course how it is. So we must ask all questions to Anette within the first half hour, and your presentation will focus on the impact of PE on quality of life and psychosocial status.
Yes.
So Anette, the floor is yours. Thank you for being here.
Thank you so much, Eric, and thank you for the kind introduction, and welcome to everybody that's taking out the morning for this, what we all think is very important work. I'm going to start out talking about the impact of pulmonary embolism on quality of life and psychosocial status. And I'm going to start out with two quotes from some of the research that I have done and some of the patients, what they have said to me in some of the interviews. Because PE is often viewed as an acute event that is resolved, but for many patients, the real impact begins at discharge. And I think these two quotes kind of hits it quite well in that. So this younger pulmonary embolism patient told me, the pulmonary embolism, will stick with me for the rest of my life, like a small cloud drifting through my consciousness, reminding me that this is how it is now. And another one telling me, if I'm in pain and can't understand what is wrong, it really makes me cry. And actually, I would say that the physical pain doing this has not been the worst. It is the mental pain that came after that was the worst. So that sets the scene for why I am today talking about both quality of life, but very much focused in on psychosocial well-being. Eric and Stefano will go into some of the other part of the post-thrombotic syndrome and all the other outcomes. But of course, I will be touching on them because the outcomes in this is, of course, interlinked and they influence each other. But why are we working with this, and what is the core of this? We know that more than half of patients with develop persisting functional limitations following pulmonary embolism. They are negatively affected by fatigue, anxiety, or subsequent fear avoidance behavior, all resulting in lower quality of life. Subsequently, this limits their patients' ability to participate in meaningful everyday life with leisure activities, family, and work life. So if we look a bit closer specifically on health-related quality of life after pulmonary embolism, we know that it is significantly lower in patients with pulmonary embolism when you compare it both to population norms, and that specifically when the first 3 months and over the first 3 months period post-diagnosis, but also that we know that it quality of life does improve over time, but it remains reduced also when you look at a 12 or 24 month point set in time. We also know that we see impaired quality of life after pregnancy-associated thrombosis and cancer-associated thrombosis. And health-related quality of life have a negative impact on both return to work, sleep, mobility, personal identity, and daily functioning. So I'm gonna just give a few slides here on factors that we know are associated with poor health-related quality of life in pulmonary embolism patients, and also where there is a decreased improvement following the pulmonary embolism. I'm not going to go into recurrence and side effect of anticoagulant treatment, of course, also affecting quality of life, but I'm going to go into some of the other factors that we know influence quality of life. So first of all, we have the chronic thromboembolic pulmonary hypertension that is only in, of course, in a very few of the patient experience this, but it does influence both quality of life at around the time of diagnosis, but also going on from there. But what we also know, and which is important, is that not just patients with chronic thromboembolic pulmonary hypertension or CTEP, but also patients that experience the post-PE syndrome is associated with worse health-related quality of life. So it is also in these patients we find a challenge with quality of life. So with other factors, looking at other factors, we know such thing as persistent dyspnea is linked to a lower quality of life, but also that patients with exercise limitations report poor quality of life, both on generic and also disease-specific measures. And important is to look at exercise as these exercise limitations are multifaceted. It is not necessarily only the physical effect on the patient that limits exercise. It can be many things. And I have a quote here from one of my patients that that describes it quite well. This lady told me, where I would normally be very active, from having a very active daily life to, well, it changed. My everyday life changed because I became much more inactive because I was in pain and I didn't dare. So it is both the physical restraints, but also the getting back to normal and having the same symptoms, experience the same symptoms as when they had the clot, and now having to deal with, is this a new clot or what is going on? So there is many things with the exercise limitations that we have to take into account. What we also know is this, that there is a better health-related quality of life reported in patients with a PE provoked by temporary risk factors. Unprovoked PE is associated with greater worry, anxiety, and psychological distress. And whether the PE was provoked or unprovoked significantly influenced perceived uncertainty among the patients. And then we have about age and sex. Younger patients show lower or poor health-related quality of life, especially in the psychological components, but also patients aged older, 70 or older, report lower quality of life, both in the physical, but also the psychological domains of quality of life. We also see less improvement in health-related quality of life at 3, 12, and 24 months in both younger and the older age groups. Women report lower quality of life scores than men, and the quality of life improvements at 3 and 6 months are less pronounced in women than men. And then finally, we have obesity, and that the higher BMI is associated with lower quality of life scores. And patients with BMI more than 30 shows less improvement in quality of life 12 months post-PE. So these are some of the factors that we know influence quality of life. Now I'm going to go on talking a bit about the psychosocial impact. We know that indicators of mental health are worse in patients with pulmonary embolism than in the general population. There is an increased prevalence of depression as well as anxiety and depressive symptoms, which then further impairs their quality of life. Both impact of event and health anxiety inventory scores exceed the threshold for mild clinical anxiety and PhD in some studies among these patients. And patients report hypervigilance, anxiety, distress, and intrusive thoughts following PE. Looking more into the social impact and the factors in this, know that PE-related worries and fear of recurrence are common, both shortly after diagnosis, but also in long term. Physical sensations or reminders of PE can trigger panic. I have a quote here from one of my younger patients. She said, "I was scared shitless and had nightmares, dreamt I burned alive." Well, at that point, all the emotional stuff began to emerge that I actually could have died. And I think this is very key in also now looking at the long-term outcomes and the consequences of this. This is not necessarily something happening when they're in the hospital, when they're receiving treatment. This is when they are back home in living, getting back to everyday life. These things emerge. We also have in many of the patient a fear of recurrence, and this is both linked to higher impact of event scale scores and reduced quality of life. This fear of recurrence often persists. It may be lessened over time, but it rarely disappears completely. And it leads to ongoing uncertainty and also heightened body awareness. As another one of the patients told me, "I've become more alert than I used to be. I can feel everything in my body now. I have to pay more attention to what my body is doing and what it is complaining about, so the next time I can respond more quickly." And this responding more quickly also relates back to the issue of delayed diagnosis that some of these patients have experienced. It goes on and it lies with them also thinking both in themselves, can I rely on my symptoms, but also will the healthcare professionals recognize it the next time? This delayed diagnosis can lead to a loss of trust in healthcare professionals. It can create uncertainty and a strong need for control. And patients feel low personal control over recurrence. This results in uncertainty in symptom management. And another one of the patient told me, when you've been through something like that, you learn to trust yourself and that you can't always blindly trust doctors. So this is some of the things they also take with them in following their pulmonary embolism diagnosis. So this was a few words on both the quality of life, mental well-being, and now I would like to give a few words and then how do we best identify and support patients after PE? Because appropriate follow-up care is crucial for monitoring recovery, identifying complication, and addressing ongoing symptoms such as dyspnea, reduced functional capacity, and psychosocial distress. As you see all what I have just presented, these patients are not just well when they're discharged. We do need to attend some of these issues that can arise after or they have afterwards. But on the flip side, there are no structured follow-up programs in most European countries, and there is considerable variation in practice patterns of post-PE management, that both within countries and between countries. And what we usually do is we then look at the guidelines. We try to follow the guidelines. What should we do to provide the most appropriate follow-up for these patients? But if we then look at the guidelines, most guidelines today are silent on PROMs, mental health, and quality of life screenings. They're simply not mentioned in them. In the ESC and the PERTH guidelines, a routine evaluation of patient at 3 to 6 months after hospital discharge is recommended. However, as you see over here in the figure, this is not across all guidelines, and it is not, there is not a consensus throughout the guidelines on how to do this and how to approach follow-up after PE. And this, of course, relying on the knowledge on optimal pathways for prevention and treatment of long-term complications, including the post-PE syndrome are lacking. We need more knowledge about what the optimal pathway is. In many other cardiovascular diseases, we have clear guidelines. We know what to do. We know who and what and when to offer rehabilitation, follow-up, and so on. That is not to the same amount the case with the pulmonary embolism patients. We need more knowledge in this field. And of course, also use the knowledge that is already there. So I'm just going to give a few words on a project that we are conducting in Denmark right now. It's a national project where we are developing, implementing, and evaluating a structured, integrated post-pulmonary embolism care model, the ATTEND-PE model. What we have done here is we have, together with clinicians, patients, and of course, based on the evidence, the best evidence, developed a post-PE follow-up structured program. It has both patient education and then a tailored program for the patient to be followed up so that we give the right follow-up to the right patients. Yeah. And then just a few take-home messages. I hope to also have the discussions with you all afterwards. But the take-home messages: PE, pulmonary embolism, is not over when the patient is discharged. There is lasting physical and psychosocial effects that impacts recovery. Integrating psychosocial care into PE management is important, and structured follow-up could have the potential to improve outcomes. Thank you. Eric, I think then we can open for discussion.
Yes, thank you, Anette, for this great presentation, also from the patient perspective. The Q&A is, as I see it correctly, still empty. So I ask the attendees, please send your questions for Anette so we can include them in our discussion. Perhaps I can start first. So you've been working very hard to optimize the aftercare of PE patients in Denmark. What do you think within the program is the best way to improve the psychosocial impact for patients? So what element is, in your view, crucial for that particular point?
Yeah, I think the very crucial point is as simple as giving the right information at the right time. That's where we at with these patients. They need structured information from clinicians that are specialized within PE. They are all they all ask for that and that was very important in our development process here as well. And that's why we have developed a national educational program. The patients are then invited in during the first week after their diagnosis. They are invited in to one session, 1.5 hours of patient education. And that is simply knowing what their medication, knowing what to expect, but also the ability to actually ask questions to a specialized professional clinician, because they have the questions, but they arise when they get home, not necessarily when they're in hospital. And giving them basic information on exercise, on how to go to resume everyday life.
Thank you, Anette. Yeah, we'll talk about patient information in the final talk as well. Maybe Stefano, do you have particular questions or remarks with regard to this presentation?
I was wondering, is there a way to, let's say, really be able to compare the quality of life before acute PE and after? Because my feeling is that this is the most challenging part, because the memories of patients are sometimes not very sharp, a bit confused, and they cannot really recall how was their state before acute PE, and therefore it's also difficult to actually provide help them with help after PE.
Yeah,
because it's difficult to estimate this.
Yeah.
What is your experience?
What we have done in the Attend, or what we are doing in the Attend program, is that we have implemented active patient-reported outcome measures at the 3 months consultation or follow-up at the hospital. So patient will have questions in advance about dyspnea, about functional status, and depression and anxiety symptoms, so that we will that way can identify the patient that might have a need for additional follow-up. And we're doing it at 3 months and not immediately after the diagnosis, because we know a lot of the patients will improve within the first 3 months, getting back to normal with not needing any help. So we are trying to point out the patients that actually do have a need for rehabilitation or for additional help.
Yeah, thank you. Now we do have questions in the Q&A. Thank you for those. We'll go through them one by one. I guess maybe a short answer if possible, Anette. First of all, this is an interesting one from Susan Bacon. She suggested hematologists are overwhelmed by a presentation. Mostly, how is this funded in Denmark? How can you set this up? Who's paying for all of this?
We have been very generously supported by the Danish Heart Foundation and the Novo Nordisk Foundation, and then we have developed it as an implementation project. So it is quality improvement really at the different sites. So and I think it's all based on the clinician were ready for this. They knew this was lacking. So they were very prepared for the implementation when we got to it. But it's we run it as quality improvement and implementation.
And there was a grant from the Danish Heart Foundation, correct?
Yes, the study is run, a grant from the Danish Heart Foundation and the Novo Nordisk Foundation.
Fantastic. Okay, next question is, can the lasting impact of PE last longer than 3 years? It's asked by Jovi Cryer.
It can for some, I would say, especially the fear, and also if they have recurrence and a recurrent event, or just the fear of a recurrent event, they might come in a situation where their risk becomes higher. Most people will, just by growing old, they will be in a higher risk again. And yeah, we do see some, but of course not the majority.
All right, and another question is, first a compliment, brilliant talk. If you could make only one change, what would you say has the highest impact on improving outcomes and quality of life? And you already mentioned information, so you have to come up with something else.
Yeah. Talking to a specialist, being able to have a specialist answer your question after discharge.
Very good. So what practical, this is a question from colleague Enoch Arona. What practical steps can be taken to improve outcomes post-PE? So practical steps, if you're not in Denmark.
I would say, first of all, which surprised us here, is some sites do not necessarily offer follow-up as a routine. So basically, actually being interested in the patients after they're discharged.
So at least have some way of following those patients
Yes.
up.
Yeah.
For medical,
and I was surprised that was where we had to start, especially if you compare it to other cardiovascular diseases, that they have experienced a traumatic medical event, and they're not necessarily seen by a specialist afterwards.
All right, then another question. How do we reassure anxious patients that they do not need rescanning after completion of anticoagulation? A lot of patients tend to live with the fear that the clot is still there.
Yeah. Again, that is back to information. And I'm so happy that you're giving the talk on this later, Eric, because it is key. A lot of these patients are influenced by the many scans that they know you have afterwards, especially within cancer. You know, you need to see if it's gone. So it's back to basic information on what is a clot how does it resolve? How does the treatment work? I think that's the basic of it. I see most patients, their shoulders go down when you give them the solid explanation on why it does not necessarily give you anything to see if it's there or not, but with a scan.
All right, we go to the next question of colleague Karadi. Do you have a specific patient information leaflet for patients to discuss post-PE syndrome? So why do you point them towards which information?
We have made general information for all patients that mentions all of these things. So what we did as part of the project is also we set down a national team, and it's now so that it also will live on after the project. It's within a VTE study group under the Danish Nurses Council. But yeah, we made information material, also the material for the education together, clinicians, patients. We made all the information also so that we have it readily available and it is updated. But we give the information basically to all patients, not necessarily only the ones with post-PE, but it's general information on dyspnea and all the other symptoms. Yeah.
All right. Dan, how can clinicians better assess and address long-term impact of post-PE syndrome and quality of life, particularly in those who report persistent symptoms despite normal follow-up imaging and tests?
First of all, is actually assessing them and seeing, are these symptoms there? Do you actually see the patient and do you assess them, or are they not seen? And of course, look at also the work we did with the outcome set in the ICHIM group and all the different outcomes that could be relevant. I don't know if that's answering enough of that question.
Well, I guess it's a difficult question because
it is, yeah.
Because if you don't have something to diagnose, if there's no CTEPH, and if there's no CTEPD or no, let's say, a true depression or clear anxiety disorder, how can you then help patients? Maybe that's the question. Perhaps, Stefano, would you like to step in here? Because it also has relations to your presentation, perhaps. So if you do not find CTEPH or persistent clots, so the patient has still limitations, what would you recommend to help this patient with?
Well, first of all, I would try to objectivize the limitations. So moving from subjective or subjectively reported limitation to objectively assessed limitations. This would help, of course, to quantify the amount of limitation and provide a degree. And actually, some patients we see there is no objective limitation, but there's still the feeling that they are limited. And usually, if you perform a functional test such as CPET, spiroergometry, actually you can spot some other causes that might explain the limitation, such as the conditioning or other cardiovascular disorders.
And do you think there is room for rehabilitation in these type of patients? So without measurable abnormalities?
I think there is room for rehabilitation for most of the general population in the Western countries, including patients with prior acute.
All right. So do you refer patients to rehabilitation? Maybe let's put it this way.
We have a pulmonary rehabilitation within the hospital. We do not refer them directly to them because usually they come from other hospitals, only if they overtly ask for it. What we, however, suggest is to keep on moving as soon as possible, namely within days after the diagnosis of acute PE. So we encourage them not only to avoid immobility, but also to be proactive and be back to the normal life, let's say, as soon as possible.
All right, thank you very much. The final question for
I
you.
Say, Eric, just a note on that. We have also that built in the 10P model that if they perform, they show something on the prompts at 3 months, we do refer to physiotherapists and rehabilitations, but not specialized, but in the communities.
Short question, short answer. Who do you suggest to give the psychosocial care to the patient if there is a psychosocial issue?
Well, what we can do now and what we do is refer them back to their GP and then give it more generally from there. I don't know if I can say who. I think that depends on also the need of the patient and the situation of the patient, because there's not just one factor in a patient's life. So it will depend on that specific situation.
But probably we can say that it should not be the PE physician, right? Because likely that the PE physician has no experience with dealing with this type of issues.
And I think it's actually but I don't know if I think it needs to be specialized either at the hospital. I think it actually found it really good at the GPs and more the whole and seeing the whole picture as they do at the GPs. I'm actually quite okay with the setup that we have right now, where it's handed back, of course, taking care of also the immediate things if there is anything, but then giving it back to the GP to take care of and refer from there to a psychologist or what is needed.
And perhaps a final question for you. As an ER doc, what can I do what's my role for post-PE syndrome and any available resource? So what can you do if you're only part of this at the very first start of the journey through VTE?
Yeah, definitely make sure they're referred rightly. I know all systems are differently, but what we have also seen in what I knew already is that some patient will be, if they have early discharge or home care with this, is there also a follow-up them? Are they referred correctly within in the different systems? And just, yeah, I think that's the main thing, especially in the ER. If it is a patient that's not necessarily have a massive pulmonary embolism, are they still referred to the specialized clinic for follow-up? Because
Thank
I
you
see
so much, Anette.
not happening here.
Thank you so much for being here, for presenting
Thank you
these
so
very
much.
important data and the Danish model. We're all very much impressed. And we know you have to go now, but thank you so much for being here. And Stefano will now take over with a lecture on the epidemiology, the diagnosis and treatment of CTEPD and CTEPH in PE survivors. And there was one final question in the Q&A, but that one I saved specifically for Stefano, so we'll get back to that later. Stefano, floor is yours.
Thank you very much, Eric. Thank you all for having me today here. So I would start with defining CTEPD and CTEPH, just to make clear what we are talking about. And the first point of discussion will be, so we cannot diagnose CTEPD or CTEPH at the time of acute PE. I know that there are emergency physicians among you, internists, so this is something for the follow-up, is not something or for the acute phase of PE. It must be highlighted, CTEPD corresponds to the presence of symptoms. And in many patients, actually, symptoms are very similar to those with CTEPH. The only difference is that usually symptoms related to pulmonary hypertension are not present in patients with chronic thromboembolic pulmonary disease. And also both groups present at follow-up with some signs of chronic clots. And these characteristics are, we will see later, are to some extent very much overlapping. For CTEPH, then we have exercise limitation due to death space ventilation, but also related to pulmonary hypertension. For CTEPD, and this is the key difference, we do not have any sign of pulmonary hypertension at rest. So you will do a CT, you will see no signs of pulmonary hypertension, right heart cath is normal at rest, echocardiography is normal at rest. However, they might develop symptoms and pulmonary hypertension if they are undergoing exercise. This is one type of phenotype of CTEPD. Or the limitation at exercise may be due more to the lack of perfusion of some lobes of the lungs, and this is another phenotype. And sometimes these two phenotypes are overlapping. So to summarize, it's however important to emphasize both groups of patients are symptomatic. There are chronic clots at CTA, but patients with CTEPD do not have pulmonary hypertension at rest. And another aspect that is very much relevant today is exactly this. So how would you define the presence of pulmonary hypertension at rest? we used to have a mean pulmonary artery pressure cutoff of 25 millimeter Hg. However, a few years ago, there was an update and general consensus of for new cutoffs, and actually this was moved down to 20 millimeter Hg. That means some patients actually with CTEPD actually suddenly could have been classified as CTEPH patients because they suddenly had pulmonary hypertension at rest, and these were patients with borderline values. The impact of this new classification concerning treatment is still unknown, and it must also be highlighted that actually the progression from a mild pulmonary hypertension towards more severe pulmonary hypertension, so in other words, from CTEPD to CTEPH, may not be so obvious. So these two conditions may be partly overlapping. The physiopathology could be similar, but there is no clear progression towards a more severe clinical and hemodynamic scenario. Very briefly, a few words on the epidemiology and risk factors. There is a nice assessment meta-analysis from Leiden on the incidence of CTEPH 2 years after index PE, and these are the values that have been updated in 2023. Approximately 3% of patients who survived acute PE would develop at 2 years and CTEPH, and the key risk factors for the development of CTEPH were right ventricular dysfunction at the time of index PE, recurrent VTE events, and the lack of identifiable risk factors for thrombosis. But there are other two aspects concerning epidemiology that are very much relevant for us today. The first is that 25% of CTEPH patients actually do not have in their past history any documentation or any information concerning prior thrombosis or pulmonary embolism. And this is quite strange. Someone postulated CTEPH could be even a separate disease, not depending on the thrombus resolution after acute pulmonary embolism, or simply they have had asymptomatic or oligosymptomatic, asymptomatic events and then led to pulmonary hypertension, but did not lead to a acute diagnosis of PE. And the second information that is also very new is the actual CTEPH prevalence. So the incidence is a very rare disease. If you consider that 3% of acute PE patients would develop it, but the prevalence in fact is a bit higher because these patients can have almost normal life and can survive many years after diagnosis. So the prevalence is now almost 6 per 100,000 population in Denmark, and this is the most recent assessment of the prevalence of CTEPH. For CTEPD, actually, we do not know what the incidence is. One could estimate that some 10–15% of survivors would be diagnosed with CTEPD, but lacking formal screening programs, actually this information is very much biased. Perhaps it's an underestimation, I would say, but more studies are ongoing. And some potential risk factors are overlapping with CTEPH, so severe PE, poor thrombus resolution depending on several factors such as suboptimal anticoagulation or thrombophilia, and recurrent VTE events are some of them. But I would like then to very briefly mention the impact of this poor thrombus resolution and residual clots after acute PE, because there is now evidence from multiple studies that having residual clots after the acute phase of PE, so 3 months, for instance, might be associated with a number of complications, more death, higher risk of getting a recurrent VTE, higher risk of getting or having residual symptoms and exercise intolerance, and higher risk of developing CTEPH. So taking all this together, we could say that residual clots are either a marker of something going on that could be inflammation, prothrombotic conditions such as cancer, etc., or could be the cause of adverse events. And then the final question would be, can early clot removal or early reperfusion treatments improve residual clots, minimize residual clots, and therefore also improve long-term outcomes? We do not know yet, but there are at least 10 studies which are ongoing, studying in reperfusion treatment that may elucidate the impact of early reperfusion on residual clots, also for the prevention of CTEPH. Let's move now to the screening and diagnosis. First of all, let's cite a study also from Leiden, defining and describing how bad and how delayed the diagnosis of CTEPH in real life is. You can see here the median diagnostic delay was 24 months. According to the guidelines, actually one could be able to diagnose CTEPH within 3 to 6 months after acute PE. Here was at least 4 times more. And we know that the diagnostic delay in CTEPH means delay in treatment and higher mortality. What do the guidelines say? So after 3 to 6 months, patients after acute PE should be assessed. These are the 2022 PH guidelines. They should be assessed for residual symptoms and potential risk factors for CTEPH. If these are present, then one should consider performing echocardiography and the perfusion imaging to describe mismatch concerning ventilation and perfusion. This is important because this is really the first step that general practitioner, internist, etc. should undertake before patients are referred then to a PH expert center in the presence of pathological findings. And second step then would be performing a CTPA with adequate setting and right heart cath. But this is something for the PH centers. So to summarize, screening at 3 months for CTEPH should include, of course, and should be focusing on assessment of residual functional limitation or dyspnea, but also asymptomatic patients with risk factors for CTEPH, for instance, splenectomy or private splenectomy, or patients who received for any reason a echocardiography and have very high pulmonary artery pressures, or who have radiological signs of chronicity for any reason in case CT was done. And then, as I said, the first step is to do echocardiography and VQ scan before sending the patient to the PH center. And this is what you would see in a VQ scan. You see some patients with pulmonary hypertension. Actually, there is no mismatch between ventilation and perfusion. That means hypertension is not depending on vascular disorders. This is the case in case there is a mismatch between ventilation, which is normal, and perfusion, which is reduced in some parts. This is indicating CTEPH or CTEPD. And then perfusion defects consistent with ventilation defects. You see here, perfusion is normal, ventilation is pathological, and this points towards lung disease and or hypoxemia, so rare disorder, thalassemia, and so on. And again, I would like to mention CTPH is only one of the many causes of PH. Actually, it is estimated that 1% of the global population has pulmonary hypertension. It is not so rare that patients coming with acute pulmonary embolism actually have other potential causes of pulmonary hypertension, and this also plays a role in the acute treatment of pulmonary embolism. How would you diagnose CTEPD? Actually, it's unknown. There is no evidence, but also no major direct consequences, because patients in real life are coming to you at 3 months. They have residual symptoms. You would like perhaps to assess this in a more objective way, perform a functional test. And this is very much overlapping with the CTEPH screening. But then CTEPH is not diagnosed, is excluded, and then you would then complete the assessment and in the end diagnose CTE-PD. But there is no clear guidelines and no clear consequence for CTE-PD diagnosis. What is, however, interesting is that there are some CTA differences between the two groups, again, at 3 months with adequate setting. So the vascular obstruction burden is very much similar. So central clots are present in both groups, and there is not a major difference concerning large clots. The main difference lays in the macrovascular in the macrovascular disease and macrovascular area, because CTEPH patients actually have a much more severe perfusion defects. CTE-PD have less involvement of the smaller vessels, and this probably explains why they did not develop pulmonary hypertension. But CTA alone cannot really distinguish between the two forms. And then very briefly on CTE-PH and CTE-PD, we know that 15% of patients with acute PE have signs of chronicity at baseline. This was the nice-Gerin paper of 2014. Then in Leiden, they assessed 6 criteria that you could actually evaluate at the time of acute PE to raise the suspicion of a pre-existing CTEPH. Not if you have just one of them, you must have at least 3 out of 6 of them. So if you have this at the time of acute PE, you may think, well, the patient might have an acute on chronic or even a CTEPH, but I should take care of the early assessment at 3 months and not forget this patient. We assessed this in an independent cohort of 300 patients. We confirmed this. And we found out that most of CTEPHs diagnosed within 2 years after acute PE were in fact pre-existing. 4 out of 5 patients with the diagnosis of CTEPH 2 years after acute PE had already signs, multiple signs of chronicity at the time of acute PE. And now this data is unpublished. We validated this again in the setting of endovascular treatment for most severe forms of acute PE. Here you see the mPAP pulmonary artery pressure after intervention, and this is the number of validated signs. You see the red dots are patients with CTEPH. We had 3 patients out of 200 patients with the diagnosed CTEPH after 2 years. All 3 patients had basically a pre-existing CTEPH, had more than 3 out of 6 criteria. And you see here, especially this group, at very high pulmonary artery pressure after reperfusion treatment in the acute setting. And this is one of these 3 patients. We thought this might be acute and chronic. This clot was actually looking a bit fresh, although the patient had some signs of chronicity, a thick right wall, very enlarged right ventricle. 3 months later, the patients underwent CTEPH screening, pulmonary endarterectomy, and actually this clot that looked perhaps fresher as the other clots on the left side was completely chronic and was removed then surgically 3 months later. So this led to an update of the InShape-4 study, again from the Netherlands, Leiden. Perhaps in the chronic or post-acute phase, one should take care of information that were collected already at the time of acute PE. So you can consider this if patients have chronic signs of PE at the time of acute PE or presumably acute PE, then this patient should be referred to echocardiography and ultimately CTEPH screening. If no signs of chronicity were present, then there is a CTEPH rule-out criteria with NT-proBNP and ECG to screen for CTEPH before the execution of echocardiography. So this is something that has been recently published and is indeed trying to integrate information concerning chronicity collected at the time of acute PE with the information that you will collect after 3 months after the acute event. So to conclude, I believe the majority of CTEPH and also of CTE-PD may be pre-existing, so patients coming with perhaps multiple events. Only the last event is really symptomatic, leading them to the emergency room. They are diagnosed with acute PE, but in most cases, they have also some chronic component, and the vast majority of CTEPH patients actually were pre-existing. This is also consistent with the fact that many CTEPH patients never had an acute PE. The consequences for the acute treatment are unknown, and there is a multi-society, multinational consensus document coming out soon, focusing on the way acute PE CT scans should be reported. And finally, the therapy. There is basically one slide to be shown for CTEPH. We have 3 well-validated therapies that are suggested or recommended by the guidelines. Central clots should be removed surgically, central chronic material. More distal obstruction can be treated with balloon angioplasty. Microvascular disease should be treated with medical therapy. And this is also the priority of interventions. First of all, patients should be assessed for operability. If not operable, then the other 2 options should be considered or are recommended, medical therapy or BPA, and the same if the patient has a recurrent CTEPH. This is how surgery works. The surgeon would dissect the chronic clot, this layer, from the PA wall. There is evidence for that. It saves lives. Delays in surgery would lead to higher mortality. This is BPA, very elegant and minimally invasive treatment. You see here an amputated lower lobe, lobar artery was wired, balloon dilatation, and suddenly the lower lobe is perfused again. Also for this, there is coming and very nice available evidence. For medical treatment, there is also extensive evidence. I will not discuss this today. And finally, all these 3 options are also available for CTPD, but there is poor evidence in this case. It has been described that endarterectomy, balloon angioplasty, and medical therapy can improve symptoms, can improve exercise tolerance. There are trials ongoing for these treatments, but today the evidence for that is limited, and the approach is very much center-based and experience-based. So it's not something that could be extrapolated and exported to all centers. And with this, I would like to thank you very much for your attention.
Thank you, Stefano. This was, again, brilliant presentation. As we know, you usually provide a fantastic overview on CTEPH and CTPD. The floor is open for questions. Please enter your questions in the Q&A. And maybe, Stefano, you just showed us the treatment of CTEPH, but also some of these treatments are being applied to patients with CTPD as well. So for CTEPH, we are in a hurry. For CTPD, we are not really in a hurry, but still, I presume that's the same flow of patients, because you refer the patients to a referral site before you make and confirm the final diagnosis. So how do you see this for PE follow-up? Do you have to distinct the 2 before you refer them, or refer them all?
So I think it's this is a very good question, but also raises the question, what would I do if I do not refer the patient? So let's say the patient has a CTPD, and let's say I didn't do an adequate assessment of symptoms. I just missed the fact that the patient has residual symptoms. What would happen if the patient is just forgotten, keeps on being anticoagulated, etc.? I think the most important part here would be to figure out what happens to CTPD patients after the chronic phase. So are they progressing really to CTPH? Are they getting other complications related to the symptoms? Of course, this could also lead to indirect complications, patients being less active because of the residual symptoms, being more prone to get weight, to get diabetes, to get cardiovascular disease. So this would be, I think, a very nice first step. In general, we refer all patients with residual symptoms. And at our, we take care of the acute treatment of acute B of the first assessment at 3 months. we complete the full assessment with biomarkers, with a nice clinical visit, thrombophilia if needed, etc. As soon as the patient suggests that he might have or she might have disturbances, we send him or her directly to the pneumology, and usually they perform a clinical visit with echocardiography as the very first step, and in most patients today, cardiopulmonary exercise testing.
Thank you so much. So there are several questions in the Q&A, and one of them is interesting. Stefano, would you be happy to share your slides upon request? So may they approach you via email?
To sell or to share?
I guess it's still to share, I don't know.
Please send me an email or through the organization, I would be happy to share it.
Very good, thanks. Going back to a question that was also asked to the previous presenter, is there a time cap on the duration of follow-up? So how long do you need to follow patients for this type of complications? Because you said many are pre-existing CTEPH, but there are also incident cases of CTEPH that develop along the way, of course.
Well, 2 years is reasonable. I showed the data concerning pre-existing versus incident cases. Actually, the 4 pre-existing CTEPH patients were diagnosed with CTEPH 3 to 4 months after acute PE. So it's a very early, very timely diagnosis. The only patient who did not receive or who did not have pre-existing CTEPH was diagnosed with CTEPH 2 years later, almost 2 years later. So I think it's important to keep on seeing these patients at 3, 6, 12 months. This is also in the guidelines, in the consensus document. So not to forget the patients. I think it's rather unlikely that patients would develop a CTEPH after 2 years. If we look also at the older papers from Pengo and other colleagues, most of the CTEPH were diagnosed in the first 6 months. And with the DOAC treatment, is also very, very unlikely that patients get recurrent events on long-term extended anticoagulation treatment. So I would keep 1 year for the, let's say, routine assessment, 3, 6, 12 and months, and then perhaps leave the patient to the family, to general practitioner, and then refer to the expert center, academic center, or second, third level center only if there is the onset of symptoms or any news that or any problem that could be then occurring.
Very good. Then I have a few specific questions, Stefano. So if you suspect CTEPH and you have a very clear CT scan that really points towards that, do you need to make a VQ scan before you refer?
You mean if you have at baseline a CT scan disease?
No, the CT during follow-up, a very clear CT scan.
Well, one could do, for, of course, a right heart cath. You may want also to have a VQ scan to compare this also for the after surgery period. I think as a reference, perhaps it's good. For the diagnosis, is right heart cath is for sure more relevant.
But probably this is for the referral center, right? So if you're not a referral center, if you have a clear CT scan, abnormal echo, you may already refer the patients. Yeah, okay.
Exactly. If you are a referral center, then usually after echo, you're already referring patient. You don't need to do a VQ scan before referring patient.
Then, would you recommend a thrombophilia screening for symptomatic patients at 3 months as part of the CTEPH workup?
Well, you know, there are three reasons why people are fighting each other: sport, politics, and thrombophilia. I would not enter the topic of thrombophilia. I would say that if there is a very high suspicion of CTEPH, I would consider performing targeted thrombophilia and perhaps focus more on antiphospholipid syndrome and antiphospholipid antibodies. Perhaps genetic thrombophilia is not that much relevant there, but perhaps this is also part of the general follow-up of this patient, not very much CTEPH dependent.
Very good. Then there's a question on cases with CTEPH where the lung perfusion is clearly abnormal, but the echo is normal. How would you proceed? Because if you follow the algorithm, if the echo is normal, it stops.
So VQ scan is pathological, echo is normal. I would do a CPET, and this might be a CTPD. And
if you're really in doubt, you still can refer the patient to your closest PH center, correct? Yes. Okay.
This would fulfill the criteria for CTPD. Yeah.
Do you think measuring troponin is relevant in the follow-up of symptomatic PE patients, especially for diagnosing CTEPH?
I don't think so. Perhaps NT-proBNP is more relevant. What we found out is that patients come sometimes in shock, sometimes with very severe acute presentation. Actually, in that case, it's relevant. We see that CTEPH patients have rather low troponin and very high NT-proBNP. The real, let's say, shock patients with acute PE, they have high proBNP and high troponin. I think this is more relevant for the acute phase.
Then could a specialist nurse help support patients with CTEPH after diagnosis, such as anticoagulation nurses do, with education, ongoing care?
Well, this is of course relevant. They have more bleedings than normal, let's say PE or VTE patients. Anticoagulation is optimal anticoagulation is unclear, whether VKA or direct oral anticoagulants. I think PH center should take care of this because this is, let's say, their patient group, and this is something that has been organized at some centers, to the best of my knowledge.
Two final short short questions, please. Short question, short answer, please. So is CTEPH more likely dependent on the type of anticoagulation used to treat PE, and what type of anticoagulation would you recommend for a patient once CTEPH is confirmed?
So I think DOACs will lead to less CTEPH compared to VKA, provided the patients are compliant. But as I mentioned, most of the CTEPH occurred not on anticoagulation, occurred before the diagnosis of acute PE. And yes, we would keep patients on DOAC if they do not develop any hemoptysis or any major bleeding. So for us, DOAC is the therapy of choice in these patients, if they do not have antiphospholipid syndrome, of course.
And then a full dose or reduced dose after 6 months?
And this is, I think, up to depends on the treatment we are planning. After surgery, I think it's reasonable to reduce 6 months after surgery to half dose. Perhaps in the other patients, I would keep them on a full dose if there is, let's say, no contraindication for it, but it's very much subjective.
And then I guess there's a final question in the chat. I would like to ask the audience to send the questions to the Q&A and leave the chat for other remarks. But if I see it very quickly, I guess they ask you whether you should refer your patient to a respiratory team or a vascular surgeon team when you refer the patient for PH treatment.
Well, this is, depends on how available experienced centers. In our case, are the pneumologists. In other centers are the cardiologists. I don't know if I got the question correctly, but this is very much, there are thorax surgeons in Germany. I think it really depends on what is available and who is taking care of the disease.
I also think that in any PH certified center, there will be a multidisciplinary approach where surgeons and pulmonologists and cardiologists are all involved. So possibly referring them to any of them will lead the patient to the correct place.
I think there's an online site where all the PH and CTEPH centers are listed. I've seen it somewhere. So actually, this is sometimes the reason why tourists coming here are actually asking us where to refer the patient or where to go if they go abroad or vice versa. So I think there is somewhere a list of all certified PH centers.
Very good. Stefano, thank you so much for your fantastic presentations. There were many, many compliments in the chat, so please read them and enjoy them. They were correct to compliment you with this presentation. May I kind of ask you to do the chairing after my presentation from the Q&A? Otherwise, it looks really strange if I keep talking all the time. Thank you. You can see the Q&A, correct? It should be somewhere on your screen. Excellent. So thank you, Stefano. So I will continue with the final presentation, and this will be, again, perhaps on a topic that you will not hear often on congresses, but I guess it's very important, and I'm very happy to have the opportunity to discuss this topic here today. And it's about communication to patients with VTE in general. I'll also be sharing my screen now. Let's see if this works. Yes, there we go. So I'm going to talk about communication to VTE patients. And it's important to realize that I have conflicts of interest, or may have conflict of interest, because I have grant and research support from also from industry. It's good to realize that when you listen to my presentation. And I'd like to start with a quote from Voltaire. He was a French philosophist and physician from hundreds of years ago. And he had a statement that it's be interesting to discuss nowadays. So the art of medicine consists in amusing the patient while nature cures a disease. I guess the last part of the quote is debatable, but the first one, that amusing the patient is relevant as well, I guess still stands. And amusing, I guess, could be translated to talking to the patient and informing the patient on their disease and their prognosis. And the relevance of this is underlined by little research, actually, but the research that is out there on communication in medicine is very clear. So when communication in medicine goes well, there's an increased patient satisfaction with the care they have received. There's an increase in recall of the information, understanding of the condition and the situation, and adherence to the therapies. There's less anxiety and other psychosocial issues that we've all learned about in the presentation of Anette. And finally, it leads to better outcomes of care from the provider point of view, and also less malpractice claims. All reasons to try to communicate well. I will just highlight a few studies in general on communication in medicine, just to show that this is really relevant. The first one is an interesting study published already in 2009, where at that point in time, they reviewed every high-quality study on the impact of good communication. And there were a couple of 100 studies in this meta-analysis, and they looked at the standardized odds ratio, very complex statistics, but ultimately they were able to pool data for all these studies to look between the association between patient adherence to treatment and the communication skill of the physician, which was measured in a standardized way across all these studies. And they identified that if the communication skill of the patient was good compared to bad, the standardized odds ratio for having better patient adherence to the treatment was 2.2. So by just having a good conversation to the patient was far more adherent to the therapy. And also, if the physician was trained to give good communication, then the communication was better, and also the outcomes was better, so the patient adherence was also better. So from this we can take that physicians can be trained in communicating well, and if they communicate well, this ends up being better for the patients. This is another interesting study. It's a much larger study. There were tens of thousands of patients in this study, which was based on a US health system, where they looked at adults aged 18 years or older with established atherosclerotic cardiovascular disease, mostly coronary artery disease. And they had categorized the patient-provider communication in either poor, average, or optimal, also measured in a standardized way. And they investigated the impact of the different types of communication on relevant outcomes. So first, on top of the table, you can see quality of life outcomes, so physical or mental health. And you can appreciate from the table that compared to the, let's say, the optimal tertile of patient provider communication, the odds for having poor physical but also mental health were between 2 and 3. So by communicating well to the patients, we increase quality of life, which is something we really have to remember for our daily practice. Also, quality of care indicators. So poor communication was associated with an odds ratio of 1.5. On poor adherence to statin use or no statin use, and the same for aspirin. Both drugs are critically important for patients with coronary artery disease, of course. Healthcare resource utilization was better when the communication was better, and also the total health care expenditure was better or lower if communication was optimal. So this, of course, is not a randomized trial. So we cannot say that because of the good communication, the outcomes were better, because we all know that there are some patients which optimal communication is extremely difficult, and those are also the patients that may have the poorest health outcomes. But still, what we can conclude from this is that if communication is successful, is very good, then there's a setting where outcomes are also better. So how about communication with VTE patients? There are only very little studies focusing on this topic, but those studies, and I will discuss them in the next slides, they really show us that VTE patients report an unmet need for clear, definitive, reliable information along the way, and they demonstrate a mistrust of healthcare providers and the healthcare system at large because of this. So actually, while we think we may be very good in communicating to our patients, we are worse than we think. The best study was done in the United States, so 4 years ago, where 24 patients were interviewed. They were consecutive patients, and they were asked for their experience, especially focused on communication. And interestingly, the authors identified a couple of aspects of healthcare providers' communication that impacted their fear and increased their fear and worsened their prognosis. And it was about word choice, incomplete information, imbalance between fear and reassurance, and non-verbal behavior. And this actually was the first study that really showed us that it's critically important to have good communication, especially in the emergency setting for patients with a diagnosed VTE. And this is a nice figure from that presentation, showing us that there is, of course, a provider and a patient part to this, and it's about the word choice used by the healthcare provider, the non-verbal communication, and the completeness of information between the provider and the patient, and ultimately how the patient then absorbs the information and processes this information that leads to ultimately an imbalance of fear over reassurance and increased anxiety and stress after the communication, and with that, poorer health outcomes as a result. And I have two quotes from this publication that I guess will be very familiar with all of us. First of all, then they told me it was like, we don't mean to come in here, but usually somebody in your situation would be on a respirator and can barely breathe on his own. And I'm like, well, you guys are like supposed to be helping me, but you're scaring me. So, well, probably the healthcare provider tried to say, well, you're doing all right. It could have been much worse. By saying it, fear was evoked that actually continued to be there for many, many months after the event. So if you say the patient of you dodged the bullet, this actually means that there was a bullet, and a patient at that point in time started to realize, or wrongly realize, that they may have died. And this again impacts, has a big impact on their lives weeks and months after the acute event. One other quote was, that's what the doctor told me, taking it every morning and don't miss. I said, what happens if I miss? He said, don't miss. That was all he said. So this is perhaps also a communication that we can all imagine that happens. Please, you explain to the patient that they should continue taking the drugs, but by doing it in this way, actually, the patient was puzzled and actually had poorer medication intake than the doctor intended to bring over. So there was a very nice editorial to this paper in RPTH by Kirsten de Wit from Canada, and she has this very nice figure in it that I also like to show you, which is more or less a summary of what was described in the study. So there are certain aspects of communication that increase fear and anxiety. For instance, information void, using jargon, alarmist words, non-verbal expression of fear, and lack of reassurance. And there are some aspects that actually improve trust and reassurance. So rapid assessment by an expert, as Anette also alluded to, quiet, seated conversation, active listening, addressing concerns, and printed and online accurate information. And there's the balance that we can either increase lasting psychosocial distress or avoid psychosocial impact. One of the interesting recommendations from this figure was that there should be clear written and online information. And this is an interesting Spanish study that looked at the quality of available online information of VTE by various medical societies, and they had to conclude that all of this information, what was found, was actually far beyond the reading grade of what you would expect from a general patient. So they were far too complex, used jargon, had too complex sentences for the patients to understand. So even in the written information patients find online, from trusted sites, the information is too difficult to comprehend, and in that way further increase possible anxiety and not helping the patient to get grip of his or her situation. And already alluded to by Anette, anxiety is a common complication of PE, of VT in general, and it was very nicely described by Rachel Hunter almost 10 years ago. She called it the post-traumatic panic syndrome. She interviewed 12 patients with a first-time DVT or PE and asked them about possible anxiety issues and what may have caused those anxiety issues. And she showed in her study that VTE in general is considered to be a life-changing event, encompassing a dynamic duality of trauma and growth. And again, this is showing us that words matter, but mostly that VTE is not only disease, it's not only clot that we have to treat with drugs or with an intervention, but there's a person surrounding the clot that also needs proper attention. And when Rachel Hunter looked at, let's say, main reasons why patients developed anxiety issues, she identified in the majority of patients there was a clear lack of information and poor communication caused as a cause for the anxiety. So what are drivers of poor communication in VTE in general? Again, as a summary of all of this, is incomplete information, but also information overload. There are multiple healthcare providers creating real or perceived discrepant messages along the patient journey. So it may be very well that the patient encounters an ER doc, a pulmonary physician, a vascular physician, a cardiologist, and they all say something different. So for myocardial infarction, you go to the cardiologist. That's just one physician. But if you have a PE, you may end up with different types of physicians in one hospital, and that will create chaos and, again, discrepant messages. Also, poor method of communication, medical jargon, metaphors, alarmist language that do not put the patient at ease, but have the other effect, the other side of the coin. And also very important, there's a lack of perceived clinician-expressed empathy. And that led us to start considering how we could improve the situation, how we could design a tool or anything, a toolbox to help physicians convey relevant information to patients on an evidence-based way and using modern communication tools. And when we started this project, we included a large faculty from across the globe to make sure that it would not be a European or a US dominated task force. There are patients, there are physicians from all types, there are nurses in it, and also healthcare communication experts. And it's interesting to learn, which was the first things we learned, that there are societies, international scientific societies about communication to patients with cancer, but there's no such thing for any other disease. So we learn to bring the message of cancer and cancer treatment, but for any other disease, it may have also a very poor prognosis comparable to that of cancer, such as acute cardiovascular diseases, there's hardly any research or evidence how communication would be optimal or how communication could help improve the outcomes of the patient. So what we do in this project and with this task force, we looked at content generation. How should the toolbox for physicians look like? We developed this toolbox and we did an open review to ask colleagues around the globe to comment on the tool and ask them for their judgment. And the content generation was, we started with mapping a VTE patient pathway with focus groups of patients. Then we conducted an inventory of all pieces of information relevant to VTE patients from the focus groups, but also from websites and brochures, anything we could find from major societies. And finally, we performed a systematic literal research to find evidence-based communication techniques for VTE patients in general, but there are hardly any. So we also looked at communication to patients, without a focus on VTE. And we asked internationally renowned communication experts to help us combine all of this in a tool that would help physicians improve their skills in talking to VTE patients. So here you can see, part of the result of our project, where you can see the patient pathway, both from the clinician point of view as well as from the patient point of view. They are mirrored here because they are, of course, closely correlated. Along the way, you can see that we came up with 3 time zones. So the immediate time period, the intermediate time period, and a long-term time period. The intermediate time period is the diagnostic encounter and also the moment when the condition or the diagnosis is communicated and the treatment is started, sometimes followed by a hospital admission, sometimes not. Then there's the intermediate time period between week 1 and month 1. And finally, there's the long-term periods in which the communication, the treatment has been established, first complications have been dealt with, and there's a, let's say, more a view on the long-term follow-up and prognosis of patients. And among this, so we mapped all relevant patients, all questions patients may have. We mapped them across those time periods, and we mirrored that to what type of information would they need at what point in time to get their questions answered. And finally, we also added evidence-based communication strategies to those specific to the different time periods or in general, to ultimately create a matrix combining all of those. And just as an example, to show you what I've learned most, is that at the ER, when we diagnose the disease, we want to tell the patient many things, but they will forget it immediately. So what we have to do at the ER is tell the patient as least as possible. Just tell them, this is your diagnosis, there's a blood clot in your leg, there's a blood clot in your lungs. The treatment consists of these drugs. You have to take them. They will thin your blood. They will prevent the clots from increasing, and they will help your body to, resolve the clots. You'll be admitted, or you can go home. If these things happen in the next few days, you must contact us and come back. And in, let's say, 1 or 2 weeks, you'll have an appointment with this and this physician or this and this department, and there all your other questions will be answered. So by avoiding this information overload, the patient gets the core information that they really need to know, let's say, to survive the first 2 weeks, and with the knowledge that they can perhaps look up on internet some information on the disease, but also that they will be able to ask all their questions in the next follow-up moment, will reassure them that they are being taken care of adequately. And this in contrast to trying to tell them everything you know about VTE, which will only lead to more to inassurance and fear and anxiety, and feel that they did not lack control of their situation. I have a short movie to show you how the tool looks like. So it's an online tool. It's a website. You can go through the different part of the matrix, either via the time pathway, questions for the patients of the types of information that should be provided. You can filter through topic, and ultimately there is also one tab on best practices on how to communicate. So which techniques do you have to use? Do you have to give much information or less information? What do you give the patient on information on forehand, all to make sure that the moment of communication is as effective as possible. And I'm very happy to share with you that this tool is part of a scientific project that will be published in the Lancet Hematology within the next few weeks. It was just not finished, the print proof today, but with the publication, which will be freely accessible without the paywall, and there will also be the link that will be released, so you can look for this tool yourself, and you can use it to improve your communication to VTE patients. This tool does not provide you with, let's say, the topics to communicate. It does not say you have to tell the patient to take the medicine for 6 months, because that's something that will be dependent on time, on the patient, etc. It will just show you what to communicate and how to communicate, and not with specifics on actual treatment recommendations. So we did an open review in which the majority, so we did this at the ISGH meeting last year in Bangkok, and the vast majority agreed that the toolkit was intuitive, easy to navigate, very clear in content, and is useful for teaching healthcare professionals on how to better communicate with PE patients. And this was all developed with the help of the North American Thrombosis Forum, who have now evolved into Vascular Network and the Dutch Thrombosis Association. And we truly hope that this will be a starting point of improving our communication skills. And with that, it's low-hanging fruit. We don't need novel treatments, not expensive interventions or novel drugs. We just need to talk better to our patients to improve their short and long-term outcomes. And with that, this was my last slide. I can see we're almost at the hour, so we have only a few minutes over for the final discussion.
Eric, we have a question from the chat. It's mentioned that sometimes physicians have different suggestions for patients. So patients are a bit anxious because they get different types of feedbacks also concerning the content of the suggestion. What is your opinion?
Yeah, so that's one of the issues, of course. I think it should be known to the physicians who the patient is talking to, and they should make sure that they have the same story. They tell the same thing. Or what you can also say, this is one of the tips, is that you know that the patient has been seen by a different type of colleague who is also has also his or her experience, and they may explain things a bit differently, but ultimately you have your own hospital protocol to follow, and you mean the same thing. But that different types of doctors may use different words or a different approach to say the same thing. You know, in types of VTE, it's impossible to do it differently, because there's not one physician that can see them through the whole course of disease.
Question from my side. So you mentioned sometimes communication from the side of the physician is not optimal. Are you assessing in your toolkit whether actually the cause for that could be that physicians are stressed, burned out? Because in my experience, sometimes communication is not optimal because there is lack of time and physicians have way much to do, and this it results in a poor communication.
Yes, exactly. That's one of the things that we talk about. So there's little research being done on how to communicate on a busy ER, but still, even on a busy ER with pages going off, very sick patients all around, if it's only 1 minute that you sit down and tell the core, so tell as few as possible would be, but take the time to for the patient. So sit down, have a very short conversation, but tell them the few things they really must know, and reassure them they'll have all the time they need to ask their questions with the next encounter with a colleague in 1 or 2 weeks. And I guess this will lead to better understanding of the patient, of their condition, and hopefully also, again, better health outcomes. All right, we are at the hour. Stefano, thank you so much for being here and providing your lecture. The audience, thank you for listening to us. Hopefully, you've learned something and you have something to discuss at your own institution. Feel free to reach out to us if you have any additional questions. We are very happy to be of service.